there's better results for the endoscopic from a satisfaction, less local complications, basically because I suppose it's a smaller incision, but all the nerve-related factors such as the strength, the range of motion, the paresthesia, these are all the same. Basically, the endoscopic gives you local advantages with regard to any associated complications. I think the patients also have less pain. So this patient comes in as a snapping of the ulnar nerve over the medial aspect. And can we do this as an endoscopic procedure as well? So we're going proximally. We can see some of the deep fascia. We're using the cautery again. And we're using here, identifying with the light, identifying where this basically portal is, similar to what we might do with endoscopic surgery or arthroscopic surgery. We've identified where the nerve is. I'm putting a retractor in. So I'm using a retractor in the same way as I would use a retractor if I was doing open surgery. I've got an artery clip on my medial intramuscular septum, and I'm just grabbing that, pulling it to the side and opening it up and then just dividing it. So this is exactly what I do when I do it as an open technique. So we just took the concepts of open surgery and took them to endoscopy. But we have the magnification, and again, you can see there's really not that many vessels in this intervals if you get the intervals correct. From a technical point of view, I'd just like to make the point how the scissors are just opening up in a small interval. If you open them up wide and you can't see the tip of the scissors, you have to take the scissors out of the endoscopic view. So if you keep them in small cuts and just advance slowly, you're then able to see exactly where you are and can do it safely. So there's the small branches or motor branches of the ulnar nerve. I've got a nylon tape sitting anteriorly, retracting the nerve, bringing it forward. You can see that there's a bit of fascia here. It's probably not a problem, but I decided to divide it so that I know that I'm safe and that there's nothing impinging. And going back proximal to the medial epicondyle, I've taken the medial intramuscular septum out. And again, you can see like a mesentery sitting there, and I divide that. So this is at the end of the procedure. We can see we've got probably a 3 centimeter incision here, but we've released this whole interval, and you can see that we're able to identify the nerve and get a complete and safe release. And when I do it as an open technique, I usually suture the medial epicondyle to the subcutaneous tissues. I usually let the tourniquet down before I finish up and do cautery under endoscopic vision and insert it local anesthetic. I keep them in a sling at 90 degrees for the first 1 week to ensure that the nerve stays anterior. That's exactly what I do when it's an open technique. But some tips and tricks that I'd recommend with endoscopic techniques: start slow, don't try and do the more complex things first. But the endoscopic ulnar nerve release is a simple and safe technique. As long as you go slow, you might choose to do this also in a cadaveric model, but I think it's something that a lot of your surgeons will be able to do and slowly build up to doing more complex techniques. So why do it endoscopically? Well, we get better visualization. I think you can see here, we're just able to open up these intervals. It just doesn't seem to bleed as much because we're in the right tissue planes versus you can see the open technique where we tend to see all this soft tissue and hematoma. Thank you very much.
Thank you. Thank you, Greg. It was an elegant technique, excellent performance. It's obviously very clear advantages. You can go up to the medial intramuscular septum, which for open you have to make a long incision. But the indication should be selective, isn't it? Those who are subluxating or significant neuropathy where you need release or infloor osteophyte, those sort of cases are not good indications, Greg?
So when we first started, we said they had to be a basic, simple technique, a simple diagnosis where there was no instability and no other pathology. But as we've got more experience, now we're looking at doing revision cases and we're looking at doing cases where there may have been fractures or other issues. But really, I think what I'd recommend is go slow, start off with the simple cases and get comfortable with that, and then you may be able to go to the more advanced cases if you become comfortable with your techniques.
Yes, Nandan, you can show your hands and you can ask your questions.
Okay, excellent presentation, Professor Bain. See, I normally do ulnar nerve decompression through a mini open, where we use a retractor and we could get to almost where you got to, but the magnification, I agree, is very useful. The biggest worry I have when I do these mini opens is when you go proximally and you have this leash of vessels around the nerve sometimes. And we don't have that, the cautery which you use, because the cautery is, it's supposed to be bipolar and it should have small tip at the end and it should be a bit bent. So that is the difficulty we have. Otherwise, we could do this even with a long nasal speculum.
Yes. The equipment that I showed you, developed by Storz, that is actually a brow facelift equipment from the plastic surgeons. And then the bipolar cautery that we showed is actually from their kit as well, that's designed for that. You're right, I think it can be done as a mini open approach, and I actually have no problem with that. I think that's reasonable. But what I've learned is doing this endoscopically. We're now doing a lot more endoscopically with regard to biceps, olecranon bursa, and other techniques. And so it's almost like you start doing that and then you feel more comfortable going to other things. And it's a little bit like doing the arthroscopy. You start off, Adam Watts showed us how to remove a loose body, and I think most people can do that. But to repair the lateral capsule and plicate it and put it back onto the epicondyle is a much more advanced technique. But you've got to learn all those basic techniques first, and then you can go ahead and start doing these more advanced techniques. So I think it's about getting familiar with all the instruments. And so it's not something I worry about doing the ulnar nerve now, but we've done a case where we identified the median nerve proximally with one of the supracondylar spurs and the Struthers ligament. We did all that endoscopically as well. Now that's quite a tricky dissection to do open. It's a bit of a tricky dissection to do endoscopically too. But what's nice is the recovery for the patient is really quite brilliant, and the magnification enables us to understand the anatomy in a different way.
Thank you.
Greg, is there any other questions? I have a question for Adam. Did you touch base on tennis elbow release, or did you tennis elbow release or repair doing arthroscopically when you choose?
So I didn't touch on that, but obviously we do offer that to patients. It's not really a problem that we see in athletes, certainly not in our professional athletes, because most of them have such good physiotherapy support that they will have a reactive tendinopathy that will be very readily addressed. It's the amateur, it's the weekend warrior, the amateur athlete that gets tennis elbow. And if obviously we do everything we can to try and avoid surgery.
My question is, if you decide to do surgery for a recalcitrant tennis elbow for over 6 month symptoms, would you choose to do just debridement of the ACRB origin, or you go for repair?
The surgery is the same. It's a debridement which inevitably then releases the tendon. But it's not necessary to do a repair, and it's not necessary to do anything to the bone. In fact, it's been shown in a randomized controlled trial. You just increase the pain. The question as to whether you do it open or arthroscopically is down to your skill as an arthroscopist, but also down to patient choice. And I let all my patients choose. And the advantages of the arthroscopic technique is that they get better more quickly, and that's been shown in a number of studies, and that's certainly reflected in my practice. You can address a plica at the same time, a posterolateral plica, which often does coexist with tennis elbow.
You have before that, Greg? Tennis elbow. Greg.
Yes, you're talking. Yeah, so we would do the same thing. We would do that as an arthroscopic procedure, and it's not a difficult thing. Basically, you create pretty close to an ordinary portal. There's a couple of little tips I'd advise you is prior to this, when you see the patient before the surgery, mark exactly where they're sore, because you don't want to miss that. And then just go in there, put a medial portal in, and just use a shaver and just debride where the area of on the lateral epicondyle. I haven't tended to repair them, but some surgeons are repairing them as well. But what's interesting, you put some local anesthetic in there. Some patients require not even Panadol. Like some patients, it's incredible. amount of, because you're really not, all we're doing is just debriding some of that soft tissue.
Just one little technical tip, Ram, for those that are doing this. Often people are taught to make quite a big fenestration in the lateral capsule, which is actually not necessary. You just need to make a window big enough so that you can see the ECRB tendon. And then if you drive through, bring your scope from the medial, anteromedial portal and drive through the joint, out through the anterolateral portal, and then essentially you're doing an endoscopic, an extra-articular procedure of debriding and releasing the tendon. So these big sort of fenestrations, which risk development of a sinus. And not
Adam, you were describing the lateral collateral ligament repair akin to rotator cuff. So would you do the repair all inside the joint intra-articular view, or you go endoscopic outside and take the sutures, retrieve and repair?
So Buddy Savoy described a technique where you use the lateral portals and you do it for basically as you would a cuff repair from the bursal side. I find that is technically more difficult. So I prefer to do an inside techniques where I'm viewing from the anteromedial portal using a 70-degree scope to look around the capitellum. But then I create an accessory lateral portal, which is just posterior to the capitellum, in line with the plane of the injury. And through that, I can bring in a grasper, I can pass my suture, I can bring the anchor in that same portal. And as I said, use fluoroscopy. So I do a sort of inside a repair from inside the joint. If you're doing
anything to add?
When I've done it, I quite like to do it in the posterior lateral compartment, but from inside the posterior lateral compartment, not extra.
Thank you. Subra, you have a question? Subramaniam, you have a question? Yeah, you have to unmute yourself.
I'm unmuted. How are you, Ram? It's a nice one. I'm just seeing it. This question to Gregory Bain, Professor Gregory Bain. This is Dr. Here I am from Madurai. Are there any specific indications how you differentiate where you are going to do open release, where you are going to arthroscopic release of your ulnar nerve? Are there any occasions where you suddenly have to go to open from endoscopic release?
Yes. So if it looks like a standard case, I would always try and do it endoscopically. If I'm doing just a release, I would nearly always be able to do it. If I'm doing a transposition, then it's more tricky. And then sometimes if there's bleeding or problem, and it doesn't take long. So to do the release probably takes 10, 11, 12 minutes, something like that. It's not a long procedure because it's just, you saw what I've shown you, it's not difficult. And the transposition probably takes about half an hour, and that's always a bit of a fiddle, just to make sure it's all right. And but most times it's just a release in my practice. The other thing that's becoming increasingly a point of conversation, and the other faculty might choose to comment on this, is the role of when to do the transposition or when to do the release. So in my practice, I try and do the release and then I assess the instability. If the nerve's just tending to slide a little bit, then I leave it. But if it's sort of going over the epicondyle, and certainly if it's snapping or clicking, then I would do the transposition. I think if you're doing a release where it's over just this sort of area, then if there's any pinching at all at either end, I think it's more likely to want to snap. But if you're releasing it over a wider area, then I think that the nerve will tend to give a bit and less likely to create the tension to go over the epicondyle. I don't know if anyone else wants to comment on that.
Yes, that is absolutely true, because if we have good flexibility, then it will stay in the groove. If we don't release enough, then it might stuck and tend to sublux. Now, another $1 million question is, if you want to transpose anteriorly, is it subcutaneous or submuscular? What is your choice?
My preference is to go to subcutaneous, and there was a time I did it mainly submuscular, but the dissections are a lot less. And if you looked at what I showed you there, that's pretty well exactly what I do with an open technique. That was how I was able to get to that technique without having to work too hard at it. Although Joydeep and Adam might have different points of view on that.
Yes, Joydeep.
But the so
Because
we would tend to do subcutaneous.
Joydeep had seen us doing submuscular in Epsom. So
No, my preference is subcutaneous,
okay.
and because I don't like the amount of potential for hematoma caused by the submuscular. The one extra thing I do is, as well as the intramuscular septum, I release the leading fascial edge of FCU. So it's another area where the nerve can pinch on. And yeah, I've been very happy with that. Then I secure it with a fat flap rather than a fascial flap.
Thank you. Nandan is asking a question to
Yeah,
Adam.
just one.
Yes.
Adam, one question regarding the capitellum. You know, I've had a few of these semi-professional badminton players, young lads with that capitellar lesion. You always struggle to get to that lesion because it's bang in the anterior aspect of the capitellum, and you know, any instruments going in the front of the elbow, you're going to be very careful about.
Yeah,
So I saw that you used a small pick which has an angle and which has a drill.
That's right.
Without that, do you have any other tips and tricks to get around that?
Yeah, you won't get it from the front of the joint. You have to go in the lateral compartment and put the elbow into deep flexion. I use a limb holder which I can adjust the position of the elbow during the arthroscopy, and I increase the flexion. In most cases, it's actually it's not a truly anterior. It's a antero-posterior, so it's in the sort of 45-degree angle. And if you flex the elbow further, you'll get it from the lateral compartment. The tricky ones are the trochlear lesions, the so-called Hageman's disease, and those you really struggle with, and often you have to do retrograde drilling for those under fluoroscopic guidance.
I thought about that retrograde, but it's very difficult to get to the target when you get to the retrograde.
Yeah, well, what you do is you put in a K-wire under fluoroscopy, and then use that K-wire. Once you've got it spot on, then you can use other wires adjacent to it. But you don't need to do that for the capitellum. That's just for the trochlear. For the capitellum, you just flex the elbow further, and you'll be able to get it from the posterior or from the lateral compartment.
And can I comment on the ulnar nerve thing? Because I think subcutaneous, you know, you were talking about subcutaneous and intramuscular or, you know, transposition. The subcutaneous is good because not only you're talking about the bleeding part or the hematoma part, what the nerve needs around a joint is the glide. And that is something we always underplay. And if you do a subcutaneous, you always have fat in the front, in the back of the nerve. So the glide of the nerve is better if you do subcutaneous. And that's one of the reasons why the tethered nerve causes problem around the elbow.
Thank you. I think we will move on to the next session for lack of time. Can I request Joydeep to talk about stiff elbow release, osteocapsular arthroplasty for arthritic indication. Thank you, Joydeep.
Okay, I'm just going to try and share my screen.
We will take the questions after the two stiff elbow talks are over. Yes, we can see.
Okay, can you see my screen?
Yes, please.
Okay, thank you, Ram, for the invite, and real pleasure to be involved. I'm going to talk about arthroscopic osteocapsular arthroplasty, and essentially I'm going to talk about some of the indications, how I plan this sort of case, and then use some case example videos. So what do we actually mean by osteocapsular arthroplasty? Well, it's a debridement of all aspects of the arthritic process. So that includes the hinging osteophytes, removing loose bodies, coronoid, olecranon, radial fossae, removing any synovitis, and the capsule, as well as the ulnar nerve. Now, you may not have to treat all of these areas for every patient, but you potentially will have to.
Sorry, you need to be on the display mode. We are seeing the slide mode.
Okay, sorry.
Go to the display.
You're in
Is that working?
mode.
Is that working?
Yeah, that's better.
Okay, I just have to swap my screens. Okay. So, what are the indications?
We can't see fully.
You can't see?
You can't see. You need to share the PowerPoint application and then go to display mode.
Okay, hold on a second.
Redo that
It's
again.
all right.
Hold on a second. So,
Greg, while Joydeep's just setting that up, can I just ask you, have you ever done the endoscopic ulnar nerve decompression and transposition with the patient in the lateral position rather than supine?
Yeah, I have. We worked backwards and forwards. It took me a while to work out which was best. Actually, I didn't talk about positioning. I should have. We'd have the patient supine and we have the arm on the table. We put like a small bucket or galley, you know, like a small thing on top of it. And then I'm sitting in the axilla. And then so my arm is, the patient's arm is back behind them, and that gives me a nice run distally. And then I bring it around to here to go proximally. So most times it would be in that position. If I'm doing degenerate elbow and I need to do scopes, I can actually do all that component of as an endoscopic procedure before going ahead with the arthroscopy. I think we should probably let Joydeep go ahead now. Joydeep.
is that working?
No, we can't see fully. It's only part of the screen is enlarged. Can you go to?
Okay, let me try this. Can you see that now?
Joydeep, I think it's just that your point's coming up as bullets.
Okay, is that better?
Yeah, I think it's fine.
Yeah.
No.
Okay, so you should be able to see indications for debridement and then a couple of bullets.
Yeah.
Okay.
Okay. So what are the indications we're talking about? So we're talking about the predominantly the patients are going to come with mechanical symptoms, which are going to be impingement pain, locking, and stiffness. And really, there are three types of pathology that are going to lead you to do a debridement procedure. The most common reason is going to be for a hypertrophic primary arthritis, osteoarthritis. And these are the patients that will get the best result. The second indication is going to be for post-traumatic arthritis and then inflammatory arthritis. And my experience has been that as we work down those different pathologies, the least durable results come with treatment for inflammatory arthritis. So what are we talking about here? So this is hypertrophic primary osteoarthritis. You can see that the patients come with impingement type pain from the olecranon and coronoid foci. What you'll notice is they actually have quite relatively preserved joint space, and their joint sits open on these osteophytes that cause the problem. So if we remove these osteophytes, their joint space is relatively good. And in these patients tend to be younger, active, and the results of arthroplasty are going to be poor in this group, but debridement good. This is another patient with post-traumatic osteoarthritis in a patient I treated with after an anterior medial coronoid fracture that was missed and treated, mismanaged elsewhere. So they get almost bone-on-bone grinding. And you'll note that they haven't got huge osteophytes, but they've got bone grinding. And this is a patient that won't do as well with a debridement procedure, even though this is an osteoarthritic picture. Then you come on to the inflammatory arthritis, and as was mentioned before, these patients have synovitis, they have marked bony erosions, and the results of debridement in this group aren't as good, although we still do it in younger patients because of the age. And conversely, they're going to do well with arthroplasty. So how do I assess these patients? Well, we look for the pattern of pain, and that's impingement pain or mid-arc pain. So patients with impingement pain are going to have a good result. And really, when you're looking for mid-arc pain, it's important to get them to load the elbow during motion. So just moving their arm is not going to provoke mid-arc pain. You have to get them to load it. And impingement pain, they're not going to have in this area, but at the end of motion. So what about their pattern of stiffness, and also what's important to the patient? So have they lost extension? Have they lost flexion? And which one do they want to gain in preference? Depending on their recreation and their work. The ulnar nerve, we examine that in detail, as well as the radiocapitellar joint. And then we formulate a rehab plan, i.e. what type of physio are they going to need, and are they going to use CPM post-op. So for the stiffer elbows, I will use CPM, but for ones, especially when I don't have to do capsular releases, I won't tend to use CPM. So ulnar nerve symptoms, I think, are underreported and underappreciated in these patients. A lot of the patients will actually present to you with an ulnar nerve problem, and underlying is osteoarthritis. Or if you examine them very carefully, you'll note that they have ulnar nerve symptoms that they haven't noticed or haven't reported to you as a feature of their problem. So that's one group where we'll do decompression and transposition, especially if you look at the axial CT and you see encroachment of osteophytes, and the cubital tunnel actually changes shape because of osteoarthritis. And then there's the other group who have quite a marked loss of flexion, where we'll do prophylactic release. And I'll do this when we're going to try and restore more than 40 degrees of flexion. And as part of that procedure, we'd be releasing the posterior MCL, which we do open, and that's in the bed of the ulnar nerve anyway. Radial head excision, well, this was quite historically common, and it was a procedure, it was sometimes the only procedure done for arthritis. But now we're very careful to select these people, and in my practice, it's actually rare to take the radial head out. I want there to be sort of undeniable evidence that the patient has radiocapitellar pain as their primary problem. So direct palpation, a grip and grind test, and maybe even local anesthetic injection to be sure. And why we're so careful? Because the effects of excision can be devastating and difficult to treat. We know that it will alter the kinematics of the elbow, it'll accelerate the ulnar humeral arthritis, and we can have problems like stump instability, proximal migration, and wrist pain that are extremely difficult to treat, such as in this case. So I think a CT scan is absolutely mandatory for when I go into these cases. I like to get a 3D and a 2D. And I actually find some aspects of the 2D CT more useful in my planning process. So this is a patient who's on my waiting list currently. He's been postponed because of the coronavirus, but he's in his 30s, and you'll note that he had an OCD lesion as a child. And I'd just like to point out some key areas that are missed. He's obviously got the big loose body at the front and impingement. The areas we really look at and are important to do to get a good result are these on. So if you look on the 3D, the so-called Mickey Mouse ears around the edges of the olecranon, if you don't remove these, the patients don't get their full potential range of extension back. In the posterolateral compartment, this little osteophyte, which is often present, will stop it, will cause impingement and pain in extension from the radial head. And then you can see the radial fossa is often neglected. So there's an osteophyte here blocking flexion, which you can also see on the axial view. And then you can see the pattern of osteophytes and what to expect in the olecranon fossa. So I look at these particular areas very carefully. So I set up in the lateral position. I use a pump and a arm holder. I think it's important to have an assistant for these cases because we often use retractors. And I have the head away from the anesthetic machine, so I have lots of space. And for other cases, when we do use X-ray, not in these, but that comes in without obstruction. So for the portals, I use 5 portals minimum to do a full elbow arthroscopy. So, and there's 3 compartments. So we have the posterior compartment, posterolateral, and the anterior compartment. And I use 2 of the portals per compartment. With this portal, the posterolateral portal used for both the posterior compartment and the posterolateral compartment. But I have no hesitation to make accessory portals. So sometimes the patient will come off the table with 9 portals and even a small incision for the ulnar nerve release. And these are portals where we can place a retractor in each compartment to make it much safer procedure. So my order of attack is, if I'm going to do the ulnar nerve, I do that first so that I can use that as an excuse to retract it and increase my margin of safety in the posterior medial part of the posterior compartment. I then do the posterior, then the posterior lateral and anterior. And I choose that because I like to maintain the capsular integrity at the front to avoid swelling. I found if I do the anterior compartment work at the front, release the capsule, then the elbow will start swelling rapidly. And we want to get a view very quickly and safely, create space, do your bony work and soft tissue work at the end to avoid the swelling. So just a few illustrative cases. See here, this is a 69-year-old man. Again, the CT shows he did have radiocapitellar pain, so we perform a radial head resection. We go into the gutters. You can see this large posterior medial osteophyte. And we check down into the lateral gutter. You can see the synovitis. There's often loose bodies hiding in these gutters, so we like to make sure there's none down there. And you can see the impingement of the electron, but also against this osteophyte here. So I do use radio frequency. I use it on low power and a pulsed manner, but I find it really dissects the osteophytes nicely. And then I use a round barrel hooded burr, and you'll note that we create a bit of a snowstorm, especially in the medial side, because there's no suction. So we stop the burr, then suck to avoid the ulnar nerve being dragged in. Elsewhere in the middle of the elbow, we will use suction more aggressively, and we'll switch burrs at times. So here we'll now go around the olecranon fossa to deepen that. Again, intermittently suck and then burr. And then the olecranon tip, we'll either use the burr as I'm doing here, or often I'll use an osteotome and a pituitary rongeur. So this is just to show the radial head resection, which we did patient. So we're coming from, we're viewing from the posterolateral portal in the posterior compartment and almost using the capitellum like a cutting block and an acromionizer to go across. And as we rotate the radial head, you can do more and more resection. We get cautious as you get the anterior part of the radial head, because you can see the anterior capsule and you don't want to suck in the anterior capsule aggressively. So what I'll tend to do, once we're happy with the degree of resection here, which we can look at, we've got this anterior rim of radial head left over. We can switch portals and finish it off from the anterior capsule. So you can see again, I tend to start with a wand to dissect the bone, just like you would do in a shoulder, and then bring the burr in and finish off the resection of the radial head from the front. So in this way, we're protecting the anterior capsule until we want to release it at the end of the case. So just to show some quite challenging cases. So this is a chap with who's had instability mediated arthritis caused by a medial condylectomy, which was done in the past quite a bit. He's only in his 50s, so we don't want to resect his radial head here because he's got valgus instability that's just going to continue, but we want to remove that large beard osteophyte. And this is really to indicate the value of a retractor where we can bring in, put the capsule under tension in front of the radial head. We kept it all intact, so we're trying to protect the nerves and then create more space so we can safely resect what we need to do. He's now 2 years out, so a good result, and avoided a total elbow replacement. So just some other areas that we treat. So the coronoid, again, sometimes I'll use use an osteotome for the coronoid. Sometimes I'll use a burr or a combination of the two. And again here, so minimal suction coming in from the anteromedial portal and viewing from anterolateral. I tend to go in with the through the anteromedial portal. In this case, when we're resecting the coronoid, you want to have a look at it, so we're viewing from the anterolateral portal. And then we can flex, extend, look for impingement, and we'll finish that off. Some problem area can be this little rim of cartilage, so I'll often bring in a osteotome just to take that away so we don't damage the trochlea. Similarly, in the anterior compartment, we need to remove the anterior osteophyte. So again, a retractor comes straight in, This is now like a subacromial decompression, a chromioplasty. You're very safe looking up against the anterior humerus. So we debride all this tissue off so we can see what we're resecting, and we have less chance of dragging in things we don't want if there's only bone being resected. So then the chromionizer burr follows, and we can resect these quite comfortably and aggressively because we're facing upwards the whole time and the capsule hasn't been released. So if we're going to do the capsule, the last thing I do, so after all the bony work's been performed, again, viewing from the anterior compartment, this time the anterior medial, I like to use a duckbill, and you see how we dissect under the capsule with the duckbill and then cut the capsule, so creating a safe plane for the duckbill, and we remove a couple of centimeters of that. Here we're just showing where the radial nerve is with the switching stick. You can see that between brachialis and brachioradialis. And then we would tend to switch portals with a switching stick. So that goes in through the scope, and then we flick the portals round. And this means you don't come in and out of the elbow repeatedly, and you can go do this very swiftly without losing your portal. So here I'm putting the wand. So that's the first thing I'm going to use when I come in. So now I'm viewing from the anterolateral portal. The retractor goes straight in, and we start clearing up space with the wand. So again, start with the wand until you can clearly see the tissues you want to release. And this is real-time footage just to show how quickly it can be done. So here you go. So again, clearing all, releasing the capsule off the anterior humerus, which gives us a bigger working space. And then finally, after the capsule has been cleared and I'm happy with the working space, we'll finish off with the duckbill to go across and take away that last bit of capsule. In the Mayo Clinic in the US, they like to aggressively remove all the capsule. I have to say, once I've done the capsulotomy, I take the edges of the capsule away with a shaver, but I don't aggressively remove all the capsule. I feel that's probably unnecessary, and also increases the risk, because now the neurovascular structures are exposed. So we just take the edges away, clean everything up as much as possible at the end. So is this safe? Well, we've actually, this paper's under review with Arthroscopy. We did a systematic review of all the cases of open debridement versus arthroscopic reported in the literature. So over 1,000 cases. And actually the perceived complication rate with arthroscopy and nerve injuries isn't there. There is a small risk, but it's not much different to the open. And it was shown that the deep infection risk and hematoma risk was much higher in the open group. So I think this is safe, but as Greg was saying, it should be a progression of your abilities towards the harder cases. Thank you very much for listening.
Thank you. Thank you, Joydeep, for the detailed presentation. Now I'll just do mine. Then we'll take the questions together. Can you see my screen?
Yeah.
Okay. So I think Joydeep has covered extensively the osteocapsular arthroplasty. This is the same sort of technique which is used in the traumatic stiff elbow. But the problem with the traumatic is it is a wide range from simple contraction to a complex post-operated stiff shoulder with the deranged joint. So you have to be careful. The indication should be very, very selective. Okay. So stiff elbow, there are many causes. I'm going to talk about the post-traumatic one. A thorough assessment, detailed history, previous surgery should be noted. Whether the patient has pain or is just only stiffness, that is very important. What is important for the patient? Flexion extension or pronosupination? And the demand on the elbow by his work or sports or activity. Not everyone with a stiff elbow will be symptomatic. Sometimes there are a lot of people who can adjust their symptoms. Examination, warmth and tenderness, that might be ongoing heterotopic ossification, be careful. The scar and soft tissue condition should be assessed. Then you have to assess the presence of a soft tissue block or bony block. neurovascular involvement, preoperative, prior nerve procedure should be noticed, X-ray, and in all sort of these cases, I'll get a CT scan. So you have treatment options: physiotherapy, serial splintage, medication or irradiation, arthroscopic release, open surgical release, or elbow replacement or salvage procedures. There's a wide range. So how do you choose? Before that, you should know how severe it is. Mild, moderate, severe, very severe. This is the arc, depending on the arc of flexion. Well, this description alone is not enough. So etiological classification by Murray into intrinsic or extrinsic. But many of the traumatic, post-traumatic condition would be a combination of both intrinsic and extrinsic. So it is becoming a descriptive classification. Sean Waterspool described a simple and complex stiffness, where we define complex as a severe contracture, multiple surgeries before, previous implants, heterotopic ossification, and a distorted bone and joint anatomy. This gives an impression of the prognosis and the surgical challenge with the complex stiffness. And we have a fantastic classification by none other than Greg Bain and Marinelli, published in the ISACOS, is a stiff classification. Stiff stands for stiffness types and influencing factors. So this is pretty useful. And this classifies the stiffness types into soft tissue contracture, arthritis, HO, that is heterotopic ossification, malunion, non-union, chronic subluxation. Then influencing factors could be ulnar symptoms, hardware, prior surgery, a ligament calcification, a skin contracture, a joint pain, whether the patient has pain or not, loose bodies. And depending on that, there is a big algorithm. If you see any algorithm like this, we get distracted. It's very difficult to focus. So what I decided to show 9 cases to see how we apply these principles. So we'll start with the case. A 43-year-old gentleman, 1 month after dislocation. The left side X-ray is immediate dislocation, and he came at 1 month with some pain and stiffness. As you see, he is already starting to develop heterotopic ossification, but the joint is stable, congruous. So I let him mobilize with endomethacin for another 6 weeks. So that is him at 2 months and 3 months. You see maturation of heterotopic ossification, and we start gentle mobilization, and that is the range of movement the patient has got despite this amount of heterotopic ossification in the front. If you keep the joint moving, the heterotopic bone forms, but it doesn't bridge across the joint. So he's happy with the outcome. So there is no surgery here. Case 2, a 32-year-old lady, right-handed, fall 8 months ago, had some indigenous treatment coming with the stiff elbow. She had good extension, but she cannot bend the elbow beyond 45 degrees. You see the X-ray and CT scan, you could see a clear malunited capitulum fracture. So there's a mechanical block, a joint incongruity. This has to be addressed here. So articular pain due to malunion. So their treatment of choice is open, a corrective osteotomy, and ORIF. So that's the plan here. She had a corrective osteotomy of the capitulum, fixation with the headless screws. That shows the range of movement at the immediate postoperative, and that is her final. And that's her final outcome now. Full range of flexion extension. So mind this as a cause of the stiff elbow. I'll move to next case. A 65-year-old lady, right-handed, fall 1 year ago, had some native treatment, and she is presenting with absolutely painful, allowing only jog of movement. If you look at it, she probably had a supracondylar fracture. You could see a line, but there is significant arthritis. So in this classification, she is arthritis number 2 and articular pain. So the treatment of choice in an elderly patient is open surgery and most likely is elbow replacement. So this is what that patient had, a total elbow arthroplasty as the primary treatment for the arthritic stiff elbow. So moving on to the other cases, this is the patient presenting with the previous multiple surgeries. And if you look at that, he's got only jog of movement, it's a fixed flexion deformity, skin contractures, previous metal work. This is a complex stiffness as per Sean Waterspool's classification, and you have many sections highlighted. So you could do something open surgeries, but many times it is better to leave things alone if it is not causing much symptoms. So case 5, a 25-year-old IT professional, road traffic accident 7 years ago. He had a lateral condyle fracture, again operated elsewhere. He's presenting with a stiff elbow, that is lack of extension. So that is his range of movement. You see is a reasonable good flexion around 110 degrees, but the fixed flexion deformity is 60 degrees. Further extension straightening is not possible. And forearm rotation, supination is there, but pronation is 40 degrees. So he has this. This is the CT scan slices. As you see, he could have you see anterior osteophyte, posterior floor osteophyte, as well as some early changes in the anterior corona and small loose bodies in the lateral compartment. So here the patient has significantly a soft tissue contracture with early bone impingement. So I decided to do arthroscopic release. And this is the classical osteocapsular arthroplasty principles followed. I do my elbow and hand surgeries routinely without any tourniquet. The patient doesn't have a regional block as well, because I want to check the nerves immediately after the patient comes off anesthesia. They might have a regional block for mobilization if required. So this is the instrumental technique, which is been already shown. So these are the 4 steps: removal of loose bodies, removal of osteophyte in the ulnofemoral joint and the 3 fossa, front and the back, total synovectomy, anterior posterior capsulotomy or capsulectomy as per the chronicity of the symptoms. So the indication for ulnar nerve release is there was a previous nerve injury in that patient, or if there is a scar on the medial side or previous open wound, or if there is a severe contracture over around 70 to 90 degrees, then as Joydeep said, we might need to make a small incision, release the nerve, release the posterior band of MCL, and then use the arthroscope. So that's the patient. We just skip a little bit. So that's the, okay. So that shows the lateral scar of the previous operation. Again, I'm going supromedial incision. The most important thing is joint inflation to keep the elbow flexed, thus minimizing the risk of neurovascular injuries. So hemostat clip is inserted, and you could have the scope first from the anteromedial portal. All the rest of the portals I make from outside in using the pink needle, and then doing every portal under vision. So once you do that, you are in the anterior compartment. You could visualize the front of the joint. As you see here, in a post-traumatic situation, you could see any sort of scarring. I go with the 3 steps. First step is the shaver, soft tissue. Second is use the thermal probe facing the bone to clear the soft tissue. Then third step is use the burr to trim the osteophyte or the floor fossa osteophyte or any bony prominence. You could see the radial head freely rotating. Now this is very important. We make a proximal anterolateral portal. This is used as a nerve retractor. So this is the regular portal, that is a proximal portal. I use the Howard elevator. You go through the proximal anterolateral portal, and then we lift the soft tissue. This is like a retractor, like an assistant retracting. Now you have a very good view of the front of the joint, capitulum, radial head, and the anterior compartment. Once you do that, you go to posterior compartment, is again midline portal, and then accessory posterolateral or posteromedial portal on 1 centimeter next to the posterior midline portal. First, you would not have any view in this post-traumatic condition. Don't wait for the wave to go tide over in the CV. You just get on. You just use the shaver, start debriding, because there is no neurovascular structure there. You see the movement is not good because we have not cleared the posterior compartment tethering. So once you start clearing the posterior compartment floor osteophyte, you could see the tip of the olecranon articulating. This is the floor of the olecranon fossa, which is filled with bone. So we just clear that with burr. So that is the olecranon fossa is cleared. Then you also trim the olecranon tip. Once you do that, you would see a smooth gliding without any impingement. So sometimes I also do screening to make sure that the entire fossa is deepened. We used to, in the past, make fenestration in the compartment, which we no longer do that. So you could see the screening, it is a full extension, near full extension is possible. So that's the end of the osteocapsular release. So the patient has cryocompression therapy for the first 24 hours. I recommend to start mobilization as soon as possible. first active, and then in 2 weeks time, full assisted. I usually give indomethacin for 6 weeks. So that is the patient in the postoperative ward is able to bend that he had before, but that is a range of extension he has. And that's the patient at 2 months follow-up with a good range of recovery of extension. The flexion has not improved any much further. And he regained full range of pronation supination. So this is an example of an arthroscopic surgery done for a selected indication. Let's move on to a few other cases. So this is a 15-year-old professional squash, under 16 national squash player. He had a history of injury, but he continued to play, and he had a progressive pain and limited movements and frequent locking of the right elbow. He can't play. He came a couple of years ago to me. And this is his CT scan and MRI scan. It shows multiple loose bodies and the posterior impingement, and posterior is like sort of valgus extension overload, and he has synovitis significant. So this is the soft tissue contracture, articular pain, also loose bodies. I think Dr. Adam Watts covered about the loose bodies, how to do. So I decided to do a arthroscopic release and removal of loose bodies here. So loose body removal is a prime indication on its own, but you have to grasp the loose body longitudinally as much as possible. Don't lose sight of it because it might slip to the anterior to posterior compartment. Then we have to spend more time. Try to take it as a whole, or my technical tip is to enlarge the portal, catch hold of it, and then retrieve a large loose body rather than breaking it in many pieces. So this is the patient post-operative after removal of these 3 loose bodies is regained good range of movement. That is him at 2 months having a pain-free, full extension and full flexion, and is back to playing sports again, and is now national level, ranked level 2 under 19 squash champion. So that's next the case, a 50-year-old man, right-handed. He had a long-term childhood injury to elbow, had been having stiff elbow, but recent increase in the pain and clicking. So that is the range of movement. What we want is flexion compared to contrast to the previous patient. So that is his X-ray. This is like a classical trauma-induced osteoarthritis, like what the cases Joydeep had shown. Again, that's the classification, and that's the treatment choice. So we can do either scope or open. I decided to do arthroscopic OCA. This is the check X-ray after the surgery. Shows the clearance of anterior posterior floor osteophyte and the tip osteophyte. So the last 2 more cases. 32-year-old man with a post-Burns contracture, and he's presenting with a stiff elbow, has about 70 degrees of flexion deformity, and he's got only another 10 degrees. So X-ray shows extensive heterotopic ossification, but the joint is looking normal. So this is HO. This is the one which I have not shown yet. So HO with skin contracture, which is influencing factor now in this particular patient scenario. So that you have to take into account. That is the beauty of this stiff classification. So what we do now, there is no chance that this will be treated arthroscopic. This has to be open. And also we had to consult with the plastic surgeon. So I decided to do this open stiff elbow release through posterior approach with the resection of bridging bone and the heterotopic bone, release both the collateral ligaments, and then en masse repair and post-op indomethacin with early full mobilization. And that is the operative technique. I use the posterior tongue Campbell approach. And then that is him at 1 month later. That's a range of movement he has got. Because of the extensive Burns contracture, I didn't bother to restore the extension, because to restore extension, he should have a plastic surgery for the anterior contracted tissue. But he is happy with the recovery of flexion. He can eat with his right hand. Okay. So this is the last case. A 29-year-old patient, 1 year post-injury, had some native treatment and is presenting like this. And that is CT scan. It was not a COVID situation, but a normal situation, but decided to have an ingenious treatment with the ending up having an extensive heterotopic bone across the joint, but he has got no pain, and the position of position of fixation is 90-degree flexion. So it is the best position he could have with arthrodesis. So it is to be left alone. So I just summarized the guidelines: stiff elbow with a congruent joint you could think about scope release in an indicated patient. A stiff elbow with a congruent joint, but with soft tissue problem, nerve injury, or a mature heterotopic ossification, you could consider mostly open release. A stiff elbow with incongruent joint, think of a salvage procedure. And a stiff elbow with heterotopic ossification, open surgery only when the heterotopic ossification is mature. To summarize, stiff elbow can be post-traumatic or arthritic. In selected patients, arthroscopic release and osteocapsular arthroplasty gives excellent results. But we have to take precautions to avoid nerve injury. If in doubt, you could always make an incision to check and release the ulnar. Open surgery has a role, especially in the presence of poor soft tissue or heterotopic ossification. Thank you. Okay, right. We will take up the questions. Let me see the chat.
Ram, can I just ask you a question?
Yes, please. Yes, Radhakant.
This is Pandey here. So basically, I saw your patient was prone.
Yes.
Is there any particular reason you don't use lateral position and go for prone position?
I routinely do all my elbow surgeries prone. I see the positioning is much easier. You just need to have arm support, and the patient is padded like the spine patient, prone, and then all you need is an arm support. You could elevate the arm support as high as you like without causing much undue pressure over the shoulder, and you can have free flexion of the elbow. That's my personal choice.
Okay, thanks.
Thank you. I think we can ask also the other panelists what position of the patient you do for elbow arthroscopy. Start with Joydeep.
Lateral.
Lateral position. Yes, Adam.
Yes, always lateral with an arm support, an arm adjustment device, so I can change the position of flexion extension depending on what I'm doing.
Yes, Greg.
Nearly always lateral, unless I want to get to the front of the elbow. So if I want to get to the front of the elbow, I have them supine, and then if I want to get to the back, I just put it over their chest. So, but that's uncommon to do that. But that way I can get to the front of the back as well. But if I go lateral, then I struggle to be able to get to the front. So supine if I need to get front to the and back.
Supine as well. Nandan.
I mostly lateral, but sometimes supine. I've used it once or twice when I had to do only the anterior compartment, release.
So nobody uses these Chinese strap traction kind of position, because if you have a very stiff elbow, sometimes it's difficult to get inside. So nobody uses any traction.
No, Mr. Pandey.
Anybody?
Because one of my colleagues does this Chinese strap thing. He hangs it. So a patient is supine, and he always does them with arm hanging. So I just thought if anybody else does it.
I think personally, my observation is that supine is a moving target, whereas a lateral position or a prone position have the elbow stationary. That's my personal observation. What do you think about supine position, Greg?
The prone, did you say?
Supine
Prone?
position arthroscopy.
So if you're doing it supine, you can have them out here to get to the front of the elbow for biceps and anterior compartment. And then if you want to go lateral, you just bring it up to like that, and you have a Lloyd Davy, I think it's called, that holds it. So instead of being the elbow like that, it's more like that. So it's a different perspective, but it can work. The concept you've described where they're putting traction on the fingers was quite popular like in the 1970s and 80s, but I think not many people use it anymore.
Okay. Thank you. Yes, Nandan?
Can I ask a quick one? Is there a,
Yes,
this is Amol from Derby. Is there a consensus amongst those presenting, and fantastic presentations by everyone, on number one, use of CPM after arthroscopic surgery, especially in the stiff elbows that we have talked about, and secondly, use of either indomethacin or similar agents as a prophylaxis in the post-release period?
yes. Let's start. Joydeep?
So I selectively use CPM for the patients where I have the stiffer elbows. So, and particularly if they're going to have a lot of capsular work done, soft tissue work, so then I would tend to use the CPM. I like it. I mean, the evidence doesn't at the moment show that CPM is superior to not using CPM, although there is an RCT running at the Mayo Clinic. But I like it because it keeps the patient in hospital. It shows them that they can achieve the full range that we've given them, and it means they concentrate and they on the recovery and they take it seriously. They have in-house physiotherapy even after the CPM. With regard to indomethacin, I don't use indomethacin. I think the compliance is poor, and I don't think it adds enough benefit. It's quite a strong drug, so I don't use it.
Yes.
So with the CPM, I don't tend to use it. My concern is it's as you say, it's a continuous passive motion. I think what's more important is the patient actively mobilizes the elbow. So that's what I want to see, is the patient flexing it right up and extending it. And the indomethacin, I only use it if the patient I see is a high risk. So the sort of cases that you've shown, I think I would use indomethacin, and I'll probably only use it for 2 weeks just to try and minimize the complications. And if I'm quite concerned about it, I would get my anaesthetist to give an intravenous anti-inflammatory as well, but that may be a bit more expensive. So Indocid's pretty cheap, so maybe that's a better option, but for 2 weeks. And I rarely use radiotherapy as well. And so the times I use radiotherapy is really the patient who's got like a spinal cord injury or a head injury as well. So that's very rare, but that's a few times I have used it.
So the radiotherapy is only when you suspect a neurogenic atrophic ossification sort of condition.
Yes.
Yes. Okay.
Yes.
In my practice, I used to do CPM in the UK, but in my practice in India, no patient has CPM. Everyone has got a plaster for 24 hours in extension, which I learned from what is called, and then straight away mobilization, active movement, and then active assisted. But we keep the patient for 2 days after the post-surgery to teach them all these exercises. They are discharged only the next day. We do not do a day care procedure. Routine, I give indomethacin for 6 weeks post-operative. Yes, Nandan?
I stopped using CPM like you in UK. I used to use it, but here I don't use it. But I have not noticed any difference in the outcomes.
Okay.
Most important thing is that you get them mobilizing actively early.
Yeah.
And I give them an interscalene catheter for 48 hours. That will help mobilize with a low dose ropivacaine. And the second thing is the indomethacin. I use it for 3 weeks, 75 milligrams SR for 3 weeks. I have used radiotherapy, focused radiotherapy for patients who've had HO.
Okay. Adam, briefly.
Similar to the others, I don't use it for arthroscopy. I do use it for open surgery, the CPM, and the indomethacin only if I'm treating HO. It's all about prevention, I think. So I would recommend the use of tranexamic acid to minimize bleeding post-operatively. If you're doing open surgery, do it without a tourniquet. You'll get less swelling and stiffness post-operatively. So it's about minimizing the stiffness and getting them moving early.
Thank you. For the constraint of time, I'll ask Greg to give his 2 talks together because it's too late for him. Thanks for staying with us, Greg. Can you start your presentation, please? The 2 talks together.
Okay, good.
You'll be excited to listen to the future of elbow arthroscopy.
So we're going on to advanced, so the new techniques. So I'm going to start off with olecranon bursectomy, and this is the sort of case, I don't know how often you get this in your practice, but this is severe rheumatoid arthritis, and we can see that this is quite a florid sort of inflammation. Many years ago, I would have managed this with an open approach. In fact, I would have tried very hard to talk this lady out of surgery if I was going to do it as an open technique, because I would have been worried about the skin. But you can see doing this endoscopically on her right elbow at 2 weeks, the wounds are pretty good. We've basically just got endoscopic telescope scars, and I think that's not a bad outcome for that sort of thing. So again, the same sort of thing using endoscopic equipment. And we're doing this as a dry endoscopy, so it's not with fluid, it's a dry thing, so we've got less swelling as we've just talked about a little bit. And then what we're doing is we're seeing here in the top right, you can see the view that we've got, you can see the hooded scope creating a space. It's a bit like putting a tent post up and creating a space within the olecranon bursal area. It preserves the skin, and in the same way as when we do other arthroscopic or endoscopic procedures, we're using portals with retractors and cauteries. So basically it's the same as doing an open or arthroscopic technique. The thing we have done is we've changed to doing what I call extra bursal technique. So we're creating the space between the subcutaneous tissues and the bursa. So we're not actually deliberately going into the bursa, we're going outside it. And the reason we're going outside it is so that we can get that space above and then clean everything else below it. If we go from within the bursa, we're taking things out towards the roof, then we'll take out some of the skin and maybe leave small sinuses. So what we want to do is prevent that. So this is a clinical case. You can see that nasty little bursa there that guy's got right on the point of his elbow. We can see the adventitious around the bursa. So we can see again, we've been able to create the tissue planes. We can see at the top where the hood is, and we're basically excising this bursa. So this is the clinical case. This is the Australian dollar. It's worth a little bit more than it was about a month ago, but basically this bursa is about the same sort of size. And some of the ones we end up using a rongeur or a pituitary rongeur to get out if we're having troubles, but if we can, we try and get it out as one piece. So we can see that this is the fellow that we've done. We can see there's incisions proximally and distally. And following the surgery, we put his elbow in a flexed position, and that tends to close it down. Previously, we admitted them, and had the elbow suspended in extension. We put drains in and all sorts of things, but having the elbow flexed, I think, is a better way to do it. It's simpler for us, it's simpler for the patient, and by having the elbow flexed, it tends to compress and hold down the space. So this is that same fellow. 1 week, you can see the skin's sucked down onto it. It's had no drains in there. The point about getting a dry bed, as some of the other speakers said, is an important one. This is a different patient who 1 week previously had an infected olecranon bursa. And again, we can see that where the bursa would be in the past, we would make an incision over the top of it. But I think the idea of making small incisions proximally and distally and then debriding it, washing it out. So we sometimes put a small gauze and railroad that through just to try and help get rid of any of the granulation tissue. I think this is a good way to do it. In this case, the wounds are not sutured. We just leave them open so that it spontaneously drains a bit. I think this is a good way to do it. So then going on to biceps bursoscopy or endoscopy, and I'd like to acknowledge Joy Deep, particularly for some of the endoscopic assisted repair work that he helped me put together. And this is the concept that we published in a couple of different places. But basically the idea is to create an anatomic footprint, so the tendon comes down onto the anatomic footprint, and then the endo button is put across to the top. And so the classification which we developed with, in fact, Adam, so Adam was very involved with that. We sat down at a few cafes quite a few times trying to work out and as fine-tune this, but basically it goes from a bursitis, partial tear, isolated head, both tendons, including the lacertus, and then becoming a delayed thing. So I think it's a fairly comprehensive classification that we still use today and helps us understand how to manage some of these cases. So one of the areas where I think bursoscopy for the bursas has been very useful in the biceps tendons, particularly these partial tears or tendonitis cases. You can see this MRI, we think part of the tendon's intact, but there's a lot of granulation tissue and rubbish in there. So this is a case with a partial tear. You can see that comes down. There's a little bit maybe of the tendon there. And if we look at this case, we can see there's like a fibrous or scarred sheath over the top of the tendon. It sort of looks like a biceps tendon, but when we do the hook test, we actually thought that it was actually not too bad, but we can see there's this like pseudo tendon and paratendon. This is the proper tendon. So these true pathological terms, Joydeep and I put together in an article for the American Academy. I think this terminology is really important to get correct, to try and understand how to describe this pathology so that we all understand the same thing. And this is the same patient. That's the hook test. So the hook test is a bit unreliable. And I think the defining point is to say whether the hook test is normal, so it's robust and strong, or whether it's what we call yielding, that when you push on it, it will tend to yield to the side, and that's not normal. And then, of course, the hook test where it's not intact at all, clearly that patient has a complete rupture of the tendon. So this is the endoscopic technique we developed many years ago. This could just be a Langenbeck retractor, or it could be a hooded scope put into here, into the bursal sheath. And I must acknowledge Deepak Bhatia with regard to his work. So this is really a mini open using retractors. What he's done is make small incisions and strategically gone through to the bursal space and then done surgical repair. So I think he's taken our technique further than we had it. And so this is the sort of view we might get of the tendon, the scope, and we're going to debride this area. So this is a clinical case with a partial tear. We've not put any fluid in here. This is all just granulation tissue and just an effusion around the tendon, and we can see this partial tear. We've gone ahead, we're now releasing this with a pair of Mayo scissors, where we debride at the axilla between the tendon and its attachment onto the tuberosity. We can then go in and debride this area using a motorized resector in the same way as we did as an arthroscopic procedure, put a bit of saline in there so that we don't burn this bone, and then we can pass sutures through. Now this is a different elbow, but basically you can see that the drill's been put through there. In fact, I think Joydeep was holding the arthroscopic camera to get these pictures, and you can see a Tui's needle being advanced with a Prolene suture, being advanced through to the posterior aspect. This is a Leahy clamp, which is a curved clamp, a bit like an artery clamp, but it's curved. And we go in and grasp that, and we then can advance the sutures through into the anatomic position and advance the tendon down onto the anatomic footprint. The other thing I just want to talk about briefly is the role of arthroscopy in arthroplasty. I'm not sure how much elbow arthroplasty is done in India. I'm sure there's a lot done in England, but basically what we're able to do is take biopsies of some of the synovitis within the joint and in the humeral stem to be able to take these targeted biopsies, and we send them off for microbiology and histopathology. Our arthroplasty unit in Adelaide here is also doing this with regard to the hip arthroplasty and the knee arthroplasty. So once we've got our biopsies, we give no antibiotics beforehand. We use a portal. We tend to do this dry. We take a fluid specimen, and what we do is create what are called matched specimens. And that's to take a specimen for microbiology and a specimen for histopathology. And what we do is we send them off together so that they're matched. So we know that this specimen is a bit from here at the interface for histology and pathology. So if it comes back and it grows on one specimen, a staph epidermidis, we go back then and see if there's any polymorphs to see if we think this is a true infection or whether it's just a contaminant. And that's why the matched specimens are useful. We identify the synovitis, any interfaces. We'll often piston the joint to see if there's any instability in what direction, and try and grab some specimens. And then following this, we give broad spectrum antibiotics, and then we delay for 2 weeks because some of these infections can be a P. acnes infection. And what we want to do is then sit down with the microbiologist and make a conscious discussion, a considered discussion as to whether we do nothing or revise it with a 1-stage or 2-stage procedure. So this is really a microbiological procedure to get a microbiological assessment of the prosthesis. We can also assess the bearings of the articulation in the Coonrad-Mori here. Some of them will be loose. And we've also, this is the arthroscope being put into the humeral canal to take out some of the bone cement up through here into the shaft. We've just got a grasper like we might use to take out a piece of meniscus in the knee. And, you know, that's quite a pleasing thing, and avoid the need to perform an osteotomy of the humerus to get it out. So we think the role of humeral shaft endoscopy and arthroplasty is a useful one to clean out any of the granulation tissue, to get biopsies and to ensure that it's all in place. This particular specimen, we were concerned that we might end up putting the prosthesis in the wrong place. So we did this as an endoscopic technique first to make sure we got it right. So these are just some of the concepts we've been working on. I think it's important to go back to the basic principles, to look at it as a diagnostic procedure for, say, the biceps tendons, or whether there be a loose prosthesis, to go ahead and do ectomy procedures such as synobectomies, removal of spurs, biopsies, those sort of things. And then we can look at doing more reconstructive procedures. With the arthroplasty, I really think it's mainly about getting a microbiological diagnosis, but we can do things like remove suture anchors and do what I call perform running repairs on some of these cases. So I think it has the advantages of minimal invasive and with magnification. Thank you. I might go on to my next talk. I think that was the plan. So
Yes.
we're going to go on to the complications. So this might be the most important talk in some regards. And a lot of the other speakers have covered this, so I'm just trying to hopefully bring some of those concepts together. This is an old paper now, but the Mayo Clinic looked at all of their complications. But really, there's 2 or 3 important things. First of all, these were experienced surgeons. They had a nerve injury to every nerve around the elbow, and that there were some complex cases such as rheumatoid arthritis and contracture release that they thought were more likely to be an issue. So there's a few important points there. So when we think about it, we've got every nerve involved. We've also got these all more pathological things. So if you've got lots of synovitis or a fracture or instability, arthroscopy becomes more difficult. And if we're using shavers or osteotomes or doing a manipulation of the joint, then we need to be a bit more concerned. And the final factor, of course, is us, the surgeon, and whether that be that we're a junior surgeon or whether we may be a bit too confident that day, or whether we're tired or getting fatigued. All of these things are important factors. The discussion about the setup has already been covered. The details of some of these are in the book that we talked about before. And when you make an incision through the skin and do your portal, it's interesting to look at the cutaneous nerves. These lie in the very depth of the subcutaneous fat. Now, this is a fairly old paper for me, but basically we made incisions over the elbow, and what we found was that the nerve lay in the very depths of the fat. So when you're doing your portal, if you make a cut in the skin and then just nick and spread, you'll find the cutaneous nerves are at the depth of the fat. So it's a good, safe way to do that. We use what we call the 2 centimeter rule, and that is all main working portals are 2 centimeters proximal to the bony landmark. So these are the main arthroscopic working portals. So when we do our infiltration, there's different ways to do this, but Denise has taught us that by putting it in the olecranon fossa is a simpler and safer way to go. I think that's right. That's how we tend to do it. And when we dilate the joint or infiltrate the joint, we can see that we create a joint space, a bit more working area for us to work in, but it does not change the distance between the capsule and the neurovascular structures, but it does take the neurovascular structures away from the articular surface. And this is another example where we can see how the radial nerve is moved away from the joint surface. There's been lots of discussion about the ulnar nerve, and I think Sean O'Driscoll's helped us here, that we should always palpate it. And then if the nerve is subluxating, we can either reduce it and then do the arthroscopy, or if we're not sure, then we should make a small open approach, identify the nerve, and make sure we're safe. In fact, for anyone who's starting arthroscopy and is really not sure where the nerve is, that would be my recommendation, to make a small open approach so that you know that you're safe. And this is an example here where the nerve had been had previous surgery and it's caught in some scar tissue. And you can see that Denise has performed an open approach, safely identified the nerve, and then gone ahead and done an arthroscopy. You can't be criticised for that. But for most cases, when you become experienced, I don't think you need to do that. But in the first cases, if there's any doubt, I think it's reasonable to do that. So on the medial side, the 2 centimeter rule would say that you go 2 centimeters proximal to the medial epicondyle, which is the superior medial portal. And this has already been shown by the other presenters, but you just go just anterior to the medial intramuscular septum and angle down into the joint. There's this other medial portal, which you can make as well, a small incision. Obviously, the median nerve and the brachial artery not that far away, and you can use a Wissenger rod from the lateral to the medial side to create that. But this would be my working portal using the 2 centimetre rule. On the lateral side, if we again go 2 centimetres proximal to the epicondyle, we come to the superior lateral portal and we go down into the articulation. This is the main working portal. There's this other portal which was described some years ago. It's not one that I think Job described this one. It's not one that I use now because it concerns me of the close proximity of the radial nerve. But this is a soft spot portal which can also be used. And particularly if you're using this portal, I think you should be considering utilizing a wrist scope. So the Wissenger rod concept, which this slide's been shown before, but basically you can railroad from side to side. This technique is safe, but you start to get a little bit close to the radial nerve on this lateral side. So this would be my main working portal on the lateral and medial sides, but you can work around the elbow in different aspects. So this box concept was something we initially developed in the wrist, but really what it's all about is just saying that there's many different portals that we can use to identify in this box space of the articulation of the joint. And the real message is get the arthroscope in the best place and get a good view so you know what you're doing. And from there, walk in one way or another, a working portal from another projection so that you can see exactly what's going on. When I first started doing arthroscopy and I had to give a talk, I went back over a lot of the videos, and what I found was that the mistake I often made when I first began was having the scope too close. Try and create a telescopic view or a panoramic view across the articulation so that you can then get a better understanding of the anatomy and use your instruments in a better way. The role of dry arthroscopy is something that we've been involved with the development of in the elbow, and I'd like to acknowledge Joydeep, who did a lot of work with us on this. So this is just using standard portals, and instead of infiltrating with saline, we're just it's just the air going through the arthroscopic cannulas. So there's no pump, there's no distension, there's no pressure. It's just the light and the scope. And so we can see as we move the elbow backwards and forwards, what's quite interesting, it's just like I've got a torch in there shining into the joint, but because we've got the synovial fluid sitting on the different aspects of the articulation, we get a better understanding of the depth of field. We can see that these folds in the soft tissue, and we get this sort of reflection. So it's more of the way that we would normally see inside the joint if we were doing it as an open procedure, or any way where we're not using saline. As soon as you use saline, you lose this reflection because it just goes saline onto the synovial fluid and there's no interface there. So we lose the reflection, we lose this depth of field, and the pressure of the saline also closes down these small vessels. So all this little pink area of perfusion with saline, that nice pink changes and folds, we lose all those perspective if we're using saline-soaked arthroscopy. So this is another example. Again, we can see the reflections, we can see the depth of field, we can see these fine folds using dry arthroscopy. And now in the lateral part, again, these sort of fine folds to see the true extent of the articulation, I think is of some value. And it's also important here in the anterior compartment. Again, we get this better visualization, and we can see a better understanding again, particularly of the stability of the articulation as it allows the whole thing to open up, and even any changes on this articular surface, any fine changes can be very clearly seen using the dry arthroscopy. And for those who wish to publish their work, I think the photographs are a lot better as well. We've already had some discussion about the retractors. I think the retractors are a good concept, particularly when doing elbow arthroscopy more so than other joints. And this is just a small Hohmann retractor off the AO set you can use. And you can see this retractor is positioned here. In fact, the point I'd like to make is that my camera is sitting in the anterior compartment, and the camera's actually holding the retractor back, so the retractor doesn't have to be held. And then we've got the resector anteriorly, and the resector's just taking out some of the osteophytes above the capitellum. So you can see we're going to get some debris in the joint. So we're going to wash that out with some low pressure irrigation and some low pressure suction, and to get rid of any of the debris, and just to get another understanding of just how useful it is with regard to the dry arthroscopy, the difference in the view. So what we find is that when we're starting to struggle with dry arthroscopy, we put the Salon out on, wash the joint out, and then we tend to go back to dry. So when we're struggling with dry, we go to wet. And if we're going to wet arthroscopy and we're having some bleeding or there's synovitis in the way, to go to dry works quite well, because then the synovitis falls out the way and any of the bleeding tends to just pull in one spot. So it tends to control the bleeding better as well. So there's a number of advantages. There is a learning curve to it. Now, Joy Deep, we did quite a lot of this together, but you'll notice Joy Deep, the videos didn't tend to use it. It is a bit of a challenge at times, and it's definitely something I feel like you have to keep working at. We're still doing it, and I still feel in some regards we're learning, but and I think it has a place. Certainly it cuts down the amount of swelling. So going on to just a little bit about the nerves. So we've got the radial nerve sitting here in this cadaveric model, and we can see the anterior capsule. So the nerve's sitting directly on top of the capsule. And in this same cadaver specimen, we can see the radial nerve where I've made a small window in the capsule, and you can see that the nerve is sitting right on the capsule. So if we're going to do any procedure in the lateral side of the elbow, we can go a bit more superior, it might be safer. But if we've got synovitis, lots of osteophytes, or we're managing a fracture, then the chance of complication really starts to escalate. This classification was mentioned previously. Thank you very much for that. But we just want to make one small point. There's this intra-articular and extra-articular, which is what Bernie Murray taught us. But there's this other group, which is just the capsule. And this is important because at arthroscopy, if it's an isolated capsular pathology, we just excise the capsule and the patient should end up with a good joint. If the patient's got these other issues where lots of heterotopic ossification, it's extra-articular, so clearly that needs to be managed with something different. And there are some with neurological conditions such as spasticity or even arthrogryposis, which has partly got a neurological component. So our approach to this would be to do the debridement. Other presenters have described this very nicely. I won't go through this in detail, but basically the technique we'd use is similar, very similar to what Joy Deep said with the basket forceps. And we would do what we call a linear capsulectomy, which is just across the top. Just take the very distal aspect, because that's much safer for the radial nerve. And we tend to leave this unless we really need to do it. So this is a subtotal capsulectomy, and we can debride this area. And we tend to just leave this now. In the past, we went out of our way to take it, but I don't think it makes a real difference. But more importantly, it means it's a little bit, I think it's safer than what we did before. And I just threw this slide into my talk when I saw those amazing images of the heterotopic ossification. This was a case that came to me where the ulnar nerve went through this HO. So please have a close look at your CT scans. And finally, the ulnar nerve sits in the gutter here. So anything in this interval, Joy Deep said very nicely how he will clean out through that area, keep the suction off, and use it in other spots. So a few tips when you're near the nerves. Use free drainage, so it's just draining out instead of using the suction. Always make sure the shaver blade that you can see it and it's away from the nerves. Make sure you can see the aperture. Bipolar cautery is safer. The use of retractors, and really it doesn't matter if we end up doing an open approach. What's more important is to be safe, and so only cut what you need to, what you want to cut, and if you're not sure, then proceed to an open. So finally, everything I've talked about is anatomy and pathology and techniques and things, but really we as the surgeon, I think a lot of the time the complications are that we probably haven't planned well enough. We may not know our instruments well enough. Training for those surgeons who haven't done a lot of arthroscopy, cadaveric courses, and visit an experienced surgeon. And if you're doing a new technique, pick your case. Don't pick the most severe case, and pick your day. Don't pick a day where you've got to go and take on the administration to do something, and have a plan B and a C plan, and bail out if you need to get away from some of these more complex things. Thank you very much.
Thank you. Thank you, Greg. That's fantastic. I think your last talk was the It's a cream. It just shows everything. Lot of full of tips and techniques. Will be extremely useful for all of us, and the most importantly for those who wish to start elbow arthroscopy. Any burning questions? I think I have a couple of questions regard to olecranon bursa endoscopic resection. What is your post-op treatment for them, Greg? And what is the chance of recurrence?
So the what we do is we just put them in. First of all, when we let the tourniquet down before we finish, and we try to endoscopically cauterize any major bleeders inside the joint. We then would irrigate that, and we put some pressure on it, and we tend to keep them in a 90-degree sling for the first week. Bernie Morey taught us some years ago that with bursa, the ones that are most likely to reoccur are rheumatoid arthritis and gout. So we've actually been pretty lucky. We haven't had any troubles with that, but there's one other group we've just recently learnt about. And a patient presented to me, and it literally was this big, like a massive bursa on the elbow, and had 2 previous surgeries. And it wasn't till we're just starting that the resident said to me that he had seen some similar things, not in the bursa, but in other areas where patients were on blood thinners. And so I think that was a factor in this particular case. So we did all the surgery, we'd had them off the blood thinners, and we were pretty happy with that. And then on the 3rd day, the patient got some chest pain, and the physician came in and they put them on heparin for a couple of days and Clexane, and so the patient then got a reoccurrence. So that's the only one we've had with a reoccurrence in recent times. So I think that's another factor that we need to bring in. And just want to know, has anyone else had a similar problem?
Because there is incidence of recurrence with open surgery. So I think that's a better choice, doing endoscopic. Yes, Adam, want to say something?
Well, I was just going to add, I have seen a complication related to the use of aspirin with endoscopic birsectomy. So I would be very cautious in a patient that's taking aspirin. Make sure they stop well ahead of your endoscopic birsectomy.
That's good.
I think any more questions? Can you see the chat, Nandan? Your dry scopy is done.
I think Karthik had a question for you.
The dry scopy is done with the tourniquet on, or the tourniquet is released to check perfusion, etc.
So I tend to do it with the tourniquet on, but you can still do it with the tourniquet on or off. That's not a game changer. Adam said before that he uses a tranexamic acid, and we do that particularly for complex cases, not for a simple case, but we do it for one of the big degenerate cases. And the other thing we do is, before I scrub up, I inject lignocaine with adrenaline into the joint. I do it on my shoulders as well. And I think that does make a difference. So I let it sit there for the 10 minutes or so while we're getting set up, and then just aspirate it with a chondrotome so that it becomes effectively like a dry scope. And I think that the tranexamic acid and the tourniquet, all those factors together, just help make it a simpler procedure, and gets rid of some of the other issues of bleeding and swelling.
Thank you. Thank you, Greg. Is there?
Sorry, Ram, can I ask if anybody used arthroscopically assisted fracture fixation like capitulum or coronoid?
Yeah, we didn't want to cover in this session, but I think Joydeep and Adam, all of us has experience. Joydeep, can you share some of those tips?
Yeah, the one where I've used it for is probably coronoid fractures. I don't particularly see a huge benefit with for radial heads, but for coronoids, it saves on quite a substantial exposure. So if the fracture is amenable to it and the coronoid needs fixing, it's a very nice, and actually once you've done it a couple of times, fairly simple technique to do.
Do you do a dry scope for those?
No, I do a wet arthroscopy for that.
The other injury that is good for arthroscopic fixation is capitellum fractures. because you can reduce those under arthroscopic vision and then bring a headless screw in from the dorsum. I agree with Joy. I think if you can fix your radial head fracture arthroscopically, it probably didn't need surgery at all. So,
True.
Thank you, everyone. Thank you, Greg Bain. I think it's too late for you. We just sorry for holding you a bit longer than we agreed. So thank you for sharing your extensive experience with us. Thanks, Joydeep. Thanks, Adam. Thanks, Nandan, and all the other SESI members who are here. As a fantastic evening, is a great eye opener for many of our young orthopedic surgeons who want to learn and do elbow arthroscopy in the country. And before closing, there is a SESI webinar on Wednesday, which is going to talk about rotator cuff consensus with expert panelists. And also, we are doing elbow arthroplasty, but not in big number, Greg. So we are planning one on next Sunday on elbow arthroplasty. So stay tuned. Thank you very much. Thank you, everyone. Thank you, Ashok.
Thank you, Rob.
Thank you. Bye-bye.
Thank you very much. Thanks. Bye.
Good night.
Yeah. How are you, Joydeep?
I'm very well, Greg. Is it still live on YouTube?
Yeah, we are. There's six participants still on there.
Okay. No, I'm well.
So,
are all the kids with you in Adelaide then, Greg, or are they out and about?
No, the Jack's in Melbourne, so he's off. So South Australia's in the borders have been closed. So
Okay.
he came back to he hasn't been back for a while, because if he comes back to Adelaide, he's in quarantine for 2 weeks.
Yeah. Are you on lockdown or not? Is it all open?
So we're actually, I hate to say this because I know that you guys are having a terrible time. We've had 10 days in a row with no new cases.
Brilliant. Brilliant.
So whereas I think I heard today England's got 600 deaths in a day, like we have been very, very lucky.
Yeah, I think we've been locked down for 6 weeks, so we're gonna, work's just changed drastically. It's been, I'm at home more with the family though, and finishing off all the paperwork and bits like this, so that's been good.
Yeah. I have to get you to start doing my arthroscopy again.
Try. I do mess around with it when I go in for a bit, but then I convert. It might be easier now. I've got a fellow for the last year, and ongoing we've got good fellows. So when you're doing it with a junior doctor and a nurse, it's too painful to try something difficult. But yeah.
Hey, I tell you, I did a case the other day, anterior Bankart fracture. Right?
Yeah.
We might have done some of those. Have you fixed many of those arthroscopically?
Yeah, not with screws though, using anchors, so the Sagaya type technique. But I've been doing those lateral position.
Why don't you use screws?
I suppose they've not been that big, the ones I've done, so they've been smaller. And then getting the, I think you're needing bigger cannulas and things for screws. So I've done the big ones open, but the smaller ones arthroscopic.
Okay.
We're working up to doing bone blocks though, arthroscopic, the bone blocks for glenoid bone blocks. So we're going to start doing those arthroscopically.
Is that a allograft from the distal tibia, or what's that? Or is that a
iliac graft? Yeah.
Okay.
Yeah. The allograft distal tibia is just so expensive. It's prohibitive. I looked at it a couple of times, but it's like, because it has to be fresh frozen for the best results. So it's like £16,000 to get a fresh frozen distal tibia.
Maybe you should start selling bones.
Yeah, it'd be a lot of things we'll be making more money at.
Yeah, no, that's true. So, and this is for the failed Latarjet?
Yeah, or primarily for bone loss. So we actually did one in we did it open, but we did one in a 15-year-old the other day with 30% bone loss. So rather than a Latarjet. And he's done really well.
Why don't you do a Latarjet on that?
Well, we didn't want to change his anatomy significantly at 15. So
all right. I've not done a 15-year-old Latarjet. I think I'm sure I've done an 18-year-old, but I had an 11-year-old patient. I don't know if it was when you were with me or not, but who had a shoulder dislocation, had almost a global tear, and I was pretty worried about that. So I wasn't sure whether you could just do an ordinary repair or not. I certainly wasn't going to do a Latarjet, but so I thought, who do I ask? Who would know about that? Because it's all about the ring apophysis and how that heals and things. So I don't know if you know Mike Houseman. He does a lot of pediatric upper limb work in New York. He's a pretty good guy. Very, very smart guy. Anyway, so I sent him an email. I said, what do you think? He said, oh, just repair it. And I said, what about the ring apophysis? And he said, oh, I had never thought about that. So maybe we over worry about things.
Sometimes too much thinking is not good.
Now, what's happening with your best? Is that?
Yeah, it's a shame. I mean, I told you it's been potentially rearranged for October, but I'm not sure. The next month or so will tell a lot about how much we're allowed to do here. So I think they're going to ease down.
Sorry?
I think they're going to ease our lockdown in the next month, but I was going to ask you whether you'll be allowed to fly.
I don't think I'll be allowed to fly into Australia. I don't think anyone will be able to fly into Australia this year.
Until they have a vaccine? Is that their plan? Or?
Well, I don't know. See, what's the good and the bad is for us that we have like literally have had 10, 11 days with no new cases in South Australia. Not deaths, no new cases. And so in Australia, there's something like 12 new cases in Australia today. So people are dying, but what I'm pleased to see, I don't want people to die, but the fact that we're not getting new cases, so we're about to come out of this in the next few weeks. So, but the problem we've got is we've got no herd immunity at all. So, I don't know anyone who's actually got it or had it. And whereas I'll bet you know lots, and I think you even said that, was it you that said they knew 2 or 3 doctors who got it? One of the Indian guys was saying they had 3 people they knew, orthopedic surgeons, who had died.
My current fellow's wife had it, so.
Yeah, exactly. So I think that our government won't let people fly into Australia.
Yeah.
So, but I think I'd rather have that than have our community be decimated. Like, it must be terrible, some of the things you've had to put up with.
Yeah, I think it's next year. I mean, it's on. We're not seeing the figures are out there, but unless you're working in intensive care or a nurse, to be honest, we're not seeing it ourselves. And the numbers in hospitals are on the decline in our hospital and around the country. So we're on the downturn, hopefully. But I saw lots of those images with Max Crespi. Brilliant, aren't they?
So I've worked quite hard to put them in my talk. So please, you're welcome to use any of them in your talks. If you can just acknowledge that they come from that book, that's all I ask.
Do you must just have a direct debit set up to him.
Well, so the thing that was nice was that is a cost paid for those. That I got 130 done.
He would have done so well out of that then. Yeah.
Well, it's 80 euros each. So it's a fair bit, but what he's got is all these templates. So he's got one of the humerus, the ulna, and although you might have seen a fair bit in the elbow, he's all over the wrist stuff. So all the EWAS group are using it. I've done quite a bit of stuff with it as well in the wrist, and so his work is brilliant though.
Yeah, he just did a nice one for me on distal biceps for a paper we had accepted. So yeah, brilliant.
Good work. Good work. Hey, Ram. You're on mute, Ram. You're mute. Can we change him?
No, I need
Yeah, I think he can hear.
Good.
to,
Well done. Thank you very much.
wait a second. I need to stop streaming. This is actually streaming live now.
I know,
Yeah.
I know.
5 people listening.
Let me just
Actually, is it? How many people are listening?
wait a second, because I'm not made a host, so I cannot control the program.
So when the hand group did one the other day, they had almost 3,000 people. So I'm worried that 4 participants is wrong.
Ashok,
Everyone's been listening to our conversation, Joydeep.
It's okay. I haven't implicated myself in any way.
you didn't say anything, right?
No, didn't implicate anyone.
Yeah.
Okay, because I just changed him to be hosted. Just hang on a second. I'll just sort it out.
So how many do you think? All right, we'll let you do that.
Only my wife rang me and said, everybody's talking. I can't see you.
Is work normal, Greg? Are you doing elective work as normal, or?
No, so the we were allowed to start doing elective work just over a week ago. So at the moment, I'm really doing complex fracture dislocations and that sort of stuff. And then, so this week, they haven't really lifted it. They've just gone to almost category 2. So because there's a $20,000 fine for any surgeon who's doing inappropriate work. So we're trying to be a little bit cautious about that.
Yeah, wow. I think it's been good though. Your government have taken a hard line against it with everything. So, which is probably why you've not got the cases, or one factor anyway.
Well, I think we're lucky we're an island, and
yeah,
and I think
so,
we're
so
lucky.
we
Yeah, I wondered that. So then we were lucky to learn from Italy and probably you, and we got most of our cases from the United States.
Yeah, I mean they're struggling, aren't they? I think they're going to be the worst.
They got, as one of my fellows says, they'll get the gold medal for the coronavirus.
Yeah.
Anyway, all right. Look forward to catching up, and nice to see you again.
Stay in touch.